herpes zoster related to the hospitalization. And imagine that's so effective the burden to the health system and to utilize for the ICU and inpatients in the hospital simply for a vaccine preventable disease. Herpes zoster contribute even not only for this, it will lead to the change in the glycemic control for diabetic patients. And among different studies, they found there is a change about the hemoglobin A1C for those affected by herpes zoster. And that's, again, that will reflect the consumptions of affect the system and even increase the complication and that's relation. Shingles and diabetes would say strongly connected to extent to presence of the former is the reason to investigate for the later. So the message that today we have to think about when we have someone herpes zoster, we have to think about diabetes. And again, if someone have a diabetes, we have to advise them they have to be risky to develop herpes zoster. So the next is about the cardiovascular disease, which is also one of the challenges here in the kingdom. And when we say cardiovascular disease, it will include atherosclerosis, myocardial infarction, pericardial disease, heart failure, and hypertension, and rhythm disorders. All these would be also considered increase of the herpes zoster development. And there's a growing evidence that the immune system with inflammation problem can contribute to increase of the herpes zoster among those patients. And the increased risk actually reaches 30% of those people have a cardiovascular disease will develop herpes zoster. Among different studies of the clinical trials and meta-analysis that indicates that almost 63% of the cases of the MRI, they could develop herpes zoster. 52% of those having ischemic heart disease will develop herpes zoster, and having heart failure will develop almost 49% of them risky to develop the herpes zoster. And in general, for all the cardiovascular patients, they consider that develop, as we mentioned for the previous slide, 34%. So again, that indicates how this is, cardiovascular disease patients would be risky to develop herpes zoster. And even the incidence will be increased, especially for the first one, as mentioned, the last study for the tongue in 2020, that the risk of developing herpes zoster reached that 13.51 among 1,000 as an incidence ratio for among the population. So definitely, as we explained for the previous slide, that cardiovascular diabetes, we focus about this physical group, definitely that there could be a risk to develop the herpes zoster. So what is the solution in our hand? We have almost the recombinant zoster vaccine, which is discovered since 10 years ago, and they almost have been investigated well in more than 18 countries in different continents of the world, and well-known studies, which is called 50 plus and 60 plus studies that recruited thousands of people, randomized, observed, blind, and it was a multinational, multi-centers, and all these studies just explain how this vaccine is safe and it can be prevent the infections. And we can see in the result of these two different studies, especially for the zoo 50, we reach the 70 or 97% of the recombinant zoster vaccine as effective and prevent the infection. And for those 70 years and above, we reach to the 91%. So if we go back again to those two risk groups that we focus about them, which is diabetic and the cardiovascular disease, we can see the effectiveness for the vaccine reached the 21 for diabetic patients and for 97% as a vaccine efficacy for the cardiovascular disease patients. And when you compare this vaccine with the previous one with live attenuated, which is not anymore used here in the kingdom, there is a huge difference between the effectiveness and also the safety profile for the sorry, someone move the slide. Yeah. So and again, and the study that demonstrate how that the effectiveness, especially with of those, if we target that 50 years old, that definitely will be get a benefit for the vaccine for this group. And as we mentioned, the studies, the ZOO 50 and ZOO 70s, having uh, study the safety profile of the vaccines, and we reported, and they reported such of them some of the side effects and adverse events, which is this not huge difference about those not receiving the vaccines. I mean, the placebo, the same in the study that. Just to compare that, having local reactions and general reactions, and there is no increase actually of the serious adverse events among these two different studies. However, still they receive of the report of the side effects, and this is part of the study. But this vaccine considered having an excellent safety profile, and it's considered as a clinically accepted. So what is the recommendation all over the kingdom? We start about all over the world. So we can start about the kingdom here, the Wiqaya, that recommended these vaccines be given as a 2 doses, part of these 2 to 6 months, according to the status of the patients. And for those high risk groups would be given at age of 18. In a state, the advisory committee immunization practice also recommend for those above 50 and more, focusing for the diabetic patient of cardiovascular disease patients. And this is my last slide, which is this is the message for colleagues, for the GPs, for the those in geriatric medicines and colleagues. How can we have to convince those visiting the clinic? I know that you have lots of clinical issues and practice that you provide to your patient for the main complaint that when they visit your clinic. However, sitting with the patients, as we mentioned here, for example, focusing about the diabetic and cardiovascular patients, to convince them about the risk of herpes zoster for these cases, and also how they the kingdom that already offered and make accessible for people to get the vaccine through the primary healthcare or the hospitals, and definitely that will make patients will be convinced about the vaccine. So when you just convince the patients, there is increase of patient interest and uptake and comply to receive the vaccine almost 3 times. So please, as a message from this presentation, if you just give your patient this is advice when they visit your clinic. This is my last slide, and thank you.
Thank you, Dr. Majid Al-Thaqafi, for a very good presentation. Definitely vaccination is a very important aspect of geriatric care, and everyone involved in the healthcare should stress and consult patients about them. And actually, sometimes not only the patients, it's also the caregiver of the patient, especially in case of dementia patient. Allah yatikum al-afiyah, jazakum Allah khair. Now we will allow for questions. If anyone has any question.
If you allow me, Dr. Samah, Dr. Walid Al-Kredi have shared a very important link that it's about, seems
Yes.
like the MOH, most updated home vaccination for the older adults. Dr. Walid, do you have any elaboration on that document that you sent or link that you shared with us? Thank you.
Thank you so much for this amazing panel and all the lectures and the moderators, and thank you so much for the Saudi Geriatric Society for such an amazing, prestigious conference. I just want to say that all these amazing efforts from a national level and from the different entities such as Wiqaya are really great in combating a real issue when it comes to vaccine hesitancy for older adults, and especially frail older adults. And in the home health care sector in particular, We deal with a lot of older, frail people who have low education, illiterate, and they depend a lot on their caregivers to make decisions when it comes to vaccines and other health choices. So I remember we partnered with some experts to first understand what's going on with this specific cohort and understand the main reasons for vaccine hesitancy and to try to combat them head on and aligning with what Dr. Ashraf had mentioned. Without understanding what's going on with the population, it would be really hard to overcome the real barriers and so on. So we came up with this protocol that we put on the website of the Ministry of Health, and we tried to circulate it in different conferences and perhaps do some awareness campaigns in collaboration with our colleagues in Waqaya to ensure that there is good awareness and promotion for the particular groups of home care and older adults. So we developed a specific card for all the adults, so a vaccine card that is tailored to all the adults, and it's mainly directed to the family medicine, GPs, and primary care providers to increase awareness about vaccination in older adults. But again, I just want to echo what Dr. Ashraf mentioned, and I have to really say that it is a challenge in my regular clinic. Even yesterday, Yashadallah, people and especially caregivers, they still are the primary driver for decision making, for making the vaccine decisions. So we really need to concert and work together in overcoming this challenge. So a lot of the time, the biggest resistance that I face in the clinic and promoting vaccination, either the shingles or the influenza or the RSV, is it comes from the caregiver.
Giver. No.
And there are certain characteristics that can help us understand who are these what distinguish these caregivers and where can we work on improving and overcoming this. One of the success stories that we did in the ministry when I used to lead the home health care is that we partnered with a patient support group. And through this patient support group, we were able to identify the main causes of vaccine hesitancy. And we were able, from 2024 to 2024-25, to increase the acceptance from 5 or 7% to 30% for the shingles vaccine. And alhamdulillah, we're able to vaccinate around 24% of the home health care in the ministry. And that happened with the great collaboration from the home health care staff and through the advocacy role. And it's a partnership, really. It started with first educating frontliners, primary caregivers, combating main drivers of vaccine hesitancy after doing a real study published in Vaccines Journal, and continuous partnership with pharma and Waqaya, our colleagues from Waqaya and so on. And the monitoring and the KPIs also plays a major role in that to encourage frontliners. So thank you so much, Dr. Ashraf, all the panels, and Dr. Amar for this amazing discussion. And I have to say, like, honestly, it does really play a huge difference, and it saves lives. And unifying the message and working together in harmony will actually make a difference. Because I 100% understand that some of the efforts are fragmented still. Also, we have a lot of entities in the kingdom, but also we need to unify the efforts from a macro level. What's going on with Uqaya, what's going on with the ministry, what's going on with the societies, so we can have an impactful result that actually translate to a real difference. Thank you so much for allowing me, and have an amazing, successful event. Take care.
Thank you, Dr. Walid. And I want to take this opportunity and this platform to applaud you and thank you for your exceptional effort over the past few years working at the Ministry of Health, home health care, as a leader of that line of service, along with the geriatric services. So thank you very much for all of your efforts. Dr. Ashraf Amir, you raised your hand for a moment there. If you have any comment before we proceed into the other questions.
No, thank you. I just would like to comment what has been said elegantly by Dr. Walid. Those people, geriatric populations at home, they are the missing group of high-risk population that we don't pay a lot of attention for. And most of the time, we are waiting for the people, for the patients to come to our clinics and to vaccinate them. In the International Medical Center, we have adapted a system where we integrate the vaccinations within every single visit to patient, regardless the specialty. Even if a pulmonologist or a cardiologist or pediatrist is going to see the patient, he should make sure that he's looking after the patient from the vaccination point of view. And I think we also discovered we have elderly patients bedridden, ventilated, intubated, with bed sores and with all comorbidities. We managed to give them the vaccination, but it was a good opportunity to sit with the other members of the family within the warmth of their home and to discuss, this kind of the importance of vaccinations on that particular setup, which is far away from the traditional setup where usually we sit in hospitals and primary care. So it was quite encouraging and appealing and promising initiative. So I would like to commend Dr. Walid. Thank you for your efforts. May Allah bless all of you, inshallah. Thank you so much.
Thank you, Dr. Ashraf. Dr. Samaha, if you allow me, there is a question that was posted by Dr. Abdullah Al-Haidari for Dr. Ashraf. Dr. Ashraf, how can the average hospitalist or internist in the private and public hospital help with the public health and family medicine initiatives in improving vaccination among adults? So this is a question from a hospitalist, internist. They want to do the same thing like family doctors and public.
I'll give you the experience in a private sector where I was working for the past 21 years. Of course, we have a data system that the responsibility of vaccination is not only rely upon the family physician or the primary care. It's across the board, all the specialties. So we have adapted the system to trigger, this kind of precious encounter. So when the patient coming to the hospital for any health issues, regardless, we should take that precious opportunity and not to have it as a missed opportunity. So the patient will be flagged as an important patient that we have to take care. So all the specialties, they will divert this patient to the vaccination clinic within that setup. So standing orders so that he don't have to be seen by a physician. So he will go directly without any waiting. So we'll make his journey more appealing and more easy to be accepted. So I think this kind of cultures, we have to change our mindset of our culture within the organization, whether hospitals, public hospital, or even private hospital, to participate in this national campaign and national objective to get into the most precious objective, which is vibrant society. Thank you.
Thank you, Dr. Ashraf. I think Dr. Marwa Musa, you have a question. If you can introduce yourself, specify the speaker you want to give the question to, you can.
Yeah.
Yes,
Hello?
we can hear you.
Okay. I'm Dr. Marwa Musa, a consultant of geriatric medicine. Thank you for all speakers for their informative and really to the point review of the revolution in geriatric medicine, KSA. Actually, I have one suggestion and two questions. The suggestion, sometimes I call the elderly senior citizen. Actually, I tried to translate them and I didn't find the translation properly in Arabic. So I hope one day we can call them مواطنين ذات المقام الرفيع. This is the point of قبل الخواطر, as our Prophet Muhammad said, actually, patients really appreciate that name when I told them,
I need minutes.
especially women. Yeah, they are,
I'm alive.
they really, yes, they are still alive and they are appreciated for all the services they get to the community. This is my first suggestion, if you allow me. My first question, sometimes family primary health care doctors ask me, doctor, please tell us when we have to refer the patient to a geriatric subspecialty. And the second question for Dr. Sulaiman, I don't know if he is the one responsible for the vaccination for shingles. The herpes zoster immunoglobulins, what's its role in patients after infection, and in what stage I can give to him to handle the complications of herpes zoster, I mean post-herpetic neuralgia. This is my questions, and thank you very much.
Dr. Sulaiman, I think the question was for you. The role of herpes zoster immunoglobulin on some of the patients who suffer from the infection.
Okay, thank you very much. If I got the question right, so vaccination should be delayed during the acute phase, Doctora, and of the shingles. It's usually wait until the rash has resolved and acute illness has improved before giving the vaccine. If I got your question correctly.
No, doctor, I don't mean the vaccine. I mean the immunoglobulins, herpes zoster immunoglobulins, not vaccine. I mean after the patient become infected, at which stage can I give him herpes zoster immunoglobulins? Because actually, I read many research regarding this, that it's hinder the complications. Do you have any experience in giving these patients who are infected in the first stage, in the stage of rash, that they can hinder post-herpetic neuralgia?
Doctor, like an IVIG for herpes zoster?
Yes,
okay.
Exactly, yes.
تفضل دكتور سلمان.
Okay, so if you mean do we use immunoglobulin for shingles? Actually, for herpes zoster immunoglobulin is mainly used post-exposure prophylaxis in high-risk individual. Though it's, as far as I know, I'll leave my colleague also to help with the question. It's not as a routine treatment for herpes zoster. So the standard treatment, it's antiviral. Though I don't have the experience giving the people immunoglobulin.
Okay. If you allow me, Doctora Marwa, I will move. Follow, Doctor.
Yeah, so this is from an infection control experience that we have. Immunoglobulin never be used for the treatment or either for prophylactic for the herpes zoster. Immunoglobulin for varicella virus used only for the varicella infection, and specifically for those immunocompromised high-risk group, especially for the pregnant women. So never ever been used as the treatment or prophylactic for the herpes zoster infection. Thank you.
Thank you, Dr. Majid. Okay, I'm going to take this opportunity to move to the next question by Dr. Maha Hussein. Dr. Maha is asking if a patient who have herpes zoster before, should they be given the vaccine or not?
Thank you, Dr. Rad and Dr. Wissam. I already mentioned that regarding if the patient got the disease before, yes, still have the risk for recurrent. So yes, we're giving the vaccine. Most important things here, it's not giving the vaccine during the acute phase. Let the rash resolve and let the acute phase go, because the recurrent up to 8%. So that's why we're still giving the vaccine, even you got the disease. Thank you.
Excellent. And usually this is also is a shared decision-making between the patient and the family. Sorry, the doctor and the patient and their family, that there is a small chance of recurrence, but yeah, it always should be like this. Okay, I probably have this question for Dr. Omar Khoja. Dr. Omar, there is a question here. What is the provision of vaccination in private care covered by insurance, depending on type of policy or self-pay mostly? I think this is a very hot topic, even though the vaccine is available at the MOH. It also can be accessed through the private sector, but sometime, not all vaccines are covered, and there might be some challenges from the insurance side about that. How we can navigate that?
Yes, thank you so much. And I think this is a great question. And in Uqaya, we are working closely with the CNHI to make sure all adult vaccine will be covered, like the children vaccine in the insurance company. And this will take time, but in CNHI and the colleagues there to make sure those vaccines it's available for everyone in the kingdom in the both sectors, in the governmental sector and in the private sector. And some of the vaccine of adult vaccines already covered in the old insurance, like influenza and some vaccines. And the other vaccines, the CNHI and the colleagues there working to be included in the insurance.
Okay, thank you, doctor. So probably we have 2.5 minutes, and this time I just want to enumerate the number of older adults vaccines that we have. We have the Shingrix or the herpes zoster, which is for 50 years and plus. It's not 50 and plus. It's not 50 up to 60, 65. It's not geriatric, but still it's for the what we consider older adults. Also, we have the pneumococcal. We have the influenza. We have the DTaP, and also there is a recently introduced vaccine, which is the RSV. But is the RSV vaccine available, and does it covered by the insurance? Is it in the mandatory older adults vaccination table or not?
Yes, thank you for this question. Like I mentioned, the RSV vaccine is part of the National Immunization Program, and it's available nowadays in all MOH and all health companies. We call the health clusters, and in the governmental sector and in the private sector. As we mentioned, we're working very closely with the CNHI to make sure those vaccine, not RSV, also the other vaccine, to make sure those to will be covered in the insurance.
Okay. Quick question, doctor. So there is a lot of, let's say, geopolitical issues going on. Would we anticipate any problem in terms of the supply chain for some of the vaccine of the older adults, or supplies are fine in that term?
Yes, thank you so much for this question. And our colleague in NEPCO, they are doing very great job, and they have huge experience to dealing with the chain supplies, and there is no any effect in the vaccine in the pediatric or the adult vaccine due to the any conflicts.
Excellent, Dr. Omar. Thank you for your assurance. Now, one last question, Dr. Sulaiman, quickly. What are the criteria? Seems to be like a question from Dr. Marwa. When to refer a patient to geriatric specialty? Very quickly.
Sorry, Dr. Trad, I did not get the question.
When to refer a patient to the geriatric specialty?
All right, that's a huge question. I'll try to minimize the answer. So, geriatric subspecialty, we are seeing many patients regarding comprehensive geriatric assessment. If the patient has, for example, memory loss, cognitive problem, geriatric syndrome, if my memory is working good right now, we're talking about if the inpatient, we have delirium, agitation, insomnia, and so on and so forth. If in the clinic, we're talking about osteoporosis, cognitive decline, dementia, also depression and anxiety, insomnia, and fall, and many things that I'm trying to remember the most things we are doing in the clinic and inpatient service. And pardon me if I missed something.
No, Doctor, you're doing very well. Thank you very much. So, by your answer, we would conclude this second session of this conference. We will have 18 and 30 seconds of break, and we will meet you all, inshallah, after at 12:40 p.m. Thank you, everyone. Thank you.